Uh, and I did want to let you know that this meeting will be recorded. We do put the events and things on our RAAP website so that people who cannot join us can come back and find it later after the event. So I just wanted everyone to be aware of that. But welcome to both the participants as well as the panelists. We're very happy to have you and look forward to the various panels and the topics of discussion this morning. Kelsey, if you'd like to move to my first slide. We'd like to thank our event sponsor, Biogen, for their support both of RAAP and of the spring workshop. Next slide, please. So we've got, as I had mentioned in a moment ago, we do have a very full agenda, and we would like to really spend some time understanding both the issues as well as some of the insights of our panelists. So you'll notice that what we will do is that we will have time for the panelists, but then we will have opportunities for you to interact with them and ask them questions. And so we're very excited. This is a much smaller venue than our autumn event, our annual meeting. And so hopefully this will give you time to really dig into some of the issues, hear from the insights of our panelists, and really get a sense of some of the areas that we can work on together to improve the access for rare patients, both in public programs as well as in private programs. As many of you know, this is our third spring workshop, and so we're very excited for this agenda. This is probably, I think, one of our strongest agendas yet, and we're very excited for this panel to move forward. You'll be able to find more information on RAAP and who we are on our website, www.rareaccessactionproject.org. And I know it's a long URL, but hopefully you'll be able to get in there and find out more about the organization, the things that we do, as well as our priorities, which we're going to review on the next slide, Kelsey. As many of you know, RAAP has been involved in the policy debates since 2018. Our core focus has always been on improving access to therapies for rare patients. And so this year, we've launched a much more robust policy agenda, and you'll be hearing more about that during the various panels. And but I wanted to give you a sense of the breadth of some of the work that RAAP is engaged in, both at the federal level as well as at the state level, whether it's from supporting enhancements to accelerated approval, the orphan drug tax credit, and really looking at a way to enhance minority participation in clinical trials, through Medicare access, both in Part D, B, and Parts A. Those are all very important areas where rare patients sometimes are finding themselves unable to get access to a therapy, whether it's the structure of the program or whether it's how the various payers that participate under the program are covering the products. And then, of course, our Medicaid priorities that focus primarily on patient and specialist participation in Medicaid decision-making, and how important that is in enhancing Medicaid programs' ability to provide access to treatment that aligns with the patient journey. And then, of course, we are just launching a state-focused program on Medigap choices to enhance access to rare disease patients in choosing their Medigap plans at the state level. So a lot going on, but I wanted to give you a sense of all the areas that RAAP is working in so that it'll give you a better sense of who we are as an organization. And with that, I would like to turn the time over to Stuart Portman, our special guest from the Senate Finance Committee. Stuart has been a key player and influencer in the development of healthcare policy in his position on the Senate Finance Committee for many years. Many of us have gotten to know Stuart through many interactions and appreciate his insights and his understanding of the issues. Anyone who's worked with Stuart has seen his enthusiasm for healthcare and the impact that healthcare has on patients. And that drives his passion in helping policymakers make informed decisions to improve the delivery of healthcare services. Stuart has been a key advisor on these important issues, including rare diseases. He served as the closest advisor to former Senator Orrin Hatch, both on the senator's personal staff and then during his chairmanship of the Senate Finance Committee. Stuart has continued to be an important voice as a member of the minority staff on the committee today. Of course, we at RAAP are grateful for the experience and leadership Stuart demonstrates in seeking the best public policy options for the patient communities in the midst of some very challenging debates that threaten both the rare disease development of new therapies and providing needed access to those therapies for rare disease patients. So with that, I'd like to turn the time over to our very special guest, Stuart Portman.
Thanks, Mike. That's a very kind introduction, and it's good to be back with everyone. I was looking at the list of participants, and there are a number of great friends that I've spoken with, and for those of you that I have not, I hope this is the start of a conversation. But it is a pleasure to be with you. I'll give the normal initial commentary that these comments are my own, not Senator Crapo's, and I will also start off by acknowledging my deep appreciation for learning so much about the rare disease space from Senator Hatch. And obviously his passing is weighs on all of us, but he has been a huge mentor in my life and has provided so much information and heart to why we need to care about the rare disease community. So all to say, definitely appreciate everyone being here today. I'll try to be a little more brief so we can spend more time in the Q&A space by saying that there is a lot of discussion on so many issues, but I don't think that there is as much on the rare space right now. And I don't necessarily think that that is a problem. We are stuck in a very political moment, and we don't want rare issues to be viewed through a political lens, because they shouldn't. It's not, as you all know, the issues that affect you are not those that fall on party lines. Who gets a rare disease does not fall on party lines. So we should try to make sure, to every extent possible, that we're not having conversations that feel like they're hitting a political moment, and instead are trying to make the broader points more fully across all those issue areas. And I appreciate hearing more about them. I would say that there is going to, the biggest issue that is coming when it comes to talking about access and different approaches is going to be more about how do we handle issues related to cell and gene therapy. I know this is, for many of you, we've talked about this together for quite a while, but the pipeline discussions that we had starting in 2018 and 19, and for some of you, 2017, in the cell and gene space, and other small molecules that are being worked on for rare diseases, those conversations are coming to a head. The pipeline discussions that started back then are going to start to rear their heads and become realities later this year, next year, and that's going to change dynamics. It's no longer a conceptual debate about access to therapies. It will become a reality. And in the world that I work in, which is primarily Medicaid and CHIP, it will be a huge problem if the low-income program that provides coverage for most of the individuals with rare diseases, especially pediatric rare diseases, doesn't have the means to cover or pay for these treatments simply because Congress couldn't figure out how to address a payment system. That is a fixable problem. So I think we're going to start to hear more of that clamoring discussion. It doesn't mean that this can be devoid of the broader politics around drug pricing that are still very much so alive, but hopefully this can be segmented away from those, because the need is not, it's not about how do we save money. It's not about, any of the political arguments related to biotech and pharma. It is solely about how do we talk about patient access and how are we making sure that the most vulnerable, and not that there is a scale of vulnerability amongst the rare disease community, but if Medicaid can't find a way to cover them, and states are going out of their ways to not cover these treatments, that is a problem. And for the federal response led by Congress can help to address it. We were encouraged to see that this administration is moving forward with the multiple best prices rule only as a way to be a positive step of, showing this is an issue on everyone's mind. And while we can continue to have hopes that there's greater coordination between FDA and CMS, I also, we all hope that that is in a positive direction and not one that is leading to less access to care. So there are a number of things that are top of mind. That's the biggest when I think of how we're trying to address rare issues, and it's really about how do we ensure that there actually is a treatment available within the Medicaid program. I think that some of the issues mentioned related to whether it's prior authorization or utilization management that states are using, there is an area of conversation that I'm sure we are going to continue to have as well here on Capitol Hill. And I think the final note that I would make, just as for brief introductory purposes, is that there are going to be a lot of discussions this year where there could be a rare discussion, right? Like we could see people wanting to have a bigger conversation on the financing side during the user fee debate. But I would say it's probably less valuable to try to bring drug pricing and financing issues into the FDA related conversations. Having those as separate and distinct is likely going to yield a better outcome, because the politics on the financing side will not work so well with the very much so needed user fee debates. And so we're very supportive of keeping those as separate and distinct discussions. I guess I said that was the final piece, but there's another, which is to say that there are other efforts underway, particularly those, here in the Finance Committee, we're spending a lot of time on mental health. The mental health work that we are doing, it touches 5 areas in particular. We had a large working group structure set up. We had an RFI last year. We're talking about workforce. We're talking about integration and coordination, parity, telehealth, and kids. How does mental health issues for youth and adolescents? So those buckets have opened up a lot of conversation. We've had 4 full committee hearings and 1 subcommittee hearing over the last 11 months. So that has really generated a lot of discussion. And I think you're going to see a lot of committee focus in the mental health space. And as part of that, as we've gone from concept to text, there has been more discussion on how do we talk about certain populations and their mental health more specifically, and not just big concepts of mental health. How are we talking about individuals with comorbidities and what those comorbidities may be? I think we will start to hear a little bit more in this space, particularly as it relates to those with the highest level of need, who frequently we only talk about their physical health needs, but they also have mental health needs. And how does that fit into the broader conversation? So I know that's a lot to throw at you, but I wanted to make sure that I covered my bases. And of course, I'm open to any and all questions.
Well, thank you, Stuart. And I will start with a question to kind of tee it up. And then we will, I've asked people to kind of raise their hand in the chat so that then I can call on and they can come off mute and ask you further follow-up questions. But we at RAAP have been really interested in some of the areas that you've discussed, and how do we work at the state level, particularly in Medicaid. As you indicated, we're looking at, low volume, high cost therapies that sometimes double in cost to Medicaid programs every 3 years. And yet the numbers are small. And we find that we are seeing increasing delays in coverage at FDA approval. And sometimes the delays can take upwards of almost 2 years to finally reach the patient at the other side of the Medicaid program. And so we've been looking at things, as you indicated, value-based pricing. We've also been exploring reinsurance and the possibility of harnessing the private sector market to provide some Medicaid solutions and access. And so my question is, as you tee that up, what are some of the solutions that you've been thinking about, and how can we help you in identifying solutions that maybe we could move forward together?
Sure, it's a great points all around. I would say that, of course, there is still there is language in the Lower Cost More Cures Act that from Senator Crapo and Senator Burr to get at some of these broader outcomes-based agreements, and they have this language has evolved from over time, and it reflects a lot of where conversations have gone. I know there are many other discussions that deal with these delayed decisions by states. I think that the lack of a clear time frame is difficult. The increasing desire of states to basically reevaluate therapies that the FDA has said are safe and effective is a problematic trend. I don't know that you're going to see Congress cut off states' ability to do that, but I think that trying to add, timelines is not an absurd perspective to add. I also think that the use of prior authorization as a delay tactic has been seen pretty frequently, especially when you have individuals that are have a very acute level of need, and if there is a delay, it could change their eligibility for a certain therapy. It's a terrible thing, and states will say that they wish they didn't have to do it, but they can't afford it from a budgetary side. But if the federal government reimbursed these products at 100%, then they would be happy to cover these products.
Right.
So I think that some of this is a conversation with states, and some of it is also just a natural disagreement between states and the federal government on the role of Medicaid. That these products are new, the investment has come from the federal government, but it doesn't mean that states don't have to have the conversation on how to adjust and how they think about prevention and how they think about long-term fixes that are not just taking things that are chronic and making them less chronic is really an amazing place to be from a scientific perspective. And so we are, I guess it's not a satisfactory answer that there isn't a clear set of solutions that we know folks will like. I think that things that will help a lot of the folks in this conversation may not necessarily be things that either Congress would like or states would like. It goes back and forth, right? And so we're trying to see if there's a package where everyone can be in a positive place. I think time is of the essence, but I also, as I tried to indicate, this isn't likely to have legs on its own at a time when there is such a politicized discussion around drug pricing. And that is an issue that we're trying to work through first and foremost. If we can sort of figure out what the pathway looks like to action, I think what Congress decides to do can come together pretty quickly because a lot of the ideas have been socialized for a while.
Thank you, Stuart. So I'd like to turn it over to all of you. If you could raise your hand through the chat, and then I'll call on you and we'll unmute. Do we have any additional questions for Stuart?
Mark has a question on FDA CMS coordination.
There you go.
Mark,
Mark,
you can go ahead and unmute.
Hi, everyone. Mark Trusheim from MIT New Digs. Great to hear you again, Stuart, and thanks for your insights as always. I've heard some rumors that Friends of Cancer Research and Duke Margolis and others are talking about coordinating evidence requirements between CMS and FDA so that we have less of this perceived need for coverage with evidence development, some of the other sorts of things you just brought up at the state level. Do you have a view on whether that's a good idea and what its prospects might be?
It's a very good question, and Mark, it's good to hear your voice. I would say that the idea that from the conversations I've had with colleagues on both sides of the aisle, I don't imagine that there would be opposition to making sure that the burden is higher for states to start to employ such decisions. I think there is a concern that states trying to act as the FDA will lead to coverage determinations that are inconsistent, and that does not help the Medicaid population writ large, and will lead to more cross-state treatment approaches that will make budget concerns even worse because it won't be effectuated in all states. So I think that from a safety and efficacy perspective, it makes sense to actually have more trust in the FDA. And when CMS can use that information they can, but trying to redetermine information or empowering states to increase their evidentiary standards is not a positive direction. And I don't think that that is a position that many of our colleagues would have. Again, this hasn't been as widely discussed, but I guess all of that is to say that there is support for FDA and CMS doing what they do best and not jumping into the other's lane. Even though they are connected, there is concern that anything on the CMS side where there is purported knowledge of what takes place on the FDA side is increasingly difficult. And while there are differences of opinion based of how accelerated approval is utilized as a pathway, I don't think there's a difference of opinion on the idea that there needs to be more of a policy-focused debate on how do we bring therapies to market and not block them. I think the desire to have more availability and then talk about pricing will continue to be a path that is supported, especially in Congress. So not a direct answer, but trying to at least get it your broader question.
Yeah. May I ask a follow-up? Is there time or not?
Yes,
Hello,
Mark.
it's a mic. Okay, thank
Yes,
you.
absolutely.
So what I'm hearing is less of a new review or getting in each other's lane, but essentially merging the lanes, having CMS engage or consult with FDA pre-approval at staged phase 2 or 3 trials to agree on endpoints and evidence requirements that then so that they align, if you will, and we don't have the second guessing. It seems complex and problematic, and I'm not sure CMS has the skills or capabilities to do that, but they could build such a capability. But have you heard of this, or is it just in the rumor mongering stage?
So I haven't heard of the same. I haven't heard the rumor that you outlined, but I would say that what you just described is something that there is support for. In all of the conversations over the years, no one has ever objected to the concept. No one outside of the agency has objected to having increased coordination at an earlier point in time between FDA and CMS. It will lead to fewer delays and in coverage of it and availability, and also gets at these wider disparities where private markets or private insurance that is trying to wait for Medicaid or Medicare determinations before making broader decisions. I don't know that will forever be the norm, especially when we have products that are going to have a much more Medicaid heavy focus, especially in the pediatric rare disease side. So the level of coordination is probably needed sooner because it will take CMS to help educate states and state pharmacy directors and CMS to help outline some protocols that could be useful to state pharmacy and therapeutics committees. And the more that they can start explaining those things, the earlier that happens, the better it will be. And the expertise of how to explain that would be better from the FDA. So that it's emerging, but keeping everyone's roles distinct as a way to actually get a product to market that can be paid for faster.
Thank you, Stuart.
If we could, we turn to Paul Howard, who has a question on outcomes-based contracts and how it might be viewed in that context. Stuart. Paul?
Thank you very much, Mike and Stuart. Great to see you. Thanks for everything that you're doing and giving us some perspective into how you see the debate shaping up. In that context, and maybe this is just a footnote to Mark's question, it would be useful, I think, as the FDA starts to think about how to use more real-world data in its decision-making process, including for accelerated approval products, for there to be discussion between CMS and FDA about how those concepts might align given the sources of data that CMS has, and how to learn to use those sources effectively where that evidence is going to be useful to patient groups, regulators, and sponsors, and companies. I think this is a really multi-stakeholder issue here, and maybe there's room to start an earlier dialogue about how to do that, given where the science is simply going around precision medicine. But just wanted to stop and get your reaction to that.
I don't disagree at all. I also would say that perhaps it's more of the snarky Hill staffers response, that I find it to be incredibly difficult that we are having in the payment side of in outpatient and inpatient care, especially the inpatient conversations in CMS, Medicaid, but especially Medicare, are all about patient experience data and talking more and more about real world experiences and how does that play into quality scores? How does that play into value-based arrangements, and how are we talking about patient experience as a way to be a key indicator for reimbursement? And yet the minute we talk about real world evidence and surrogate endpoints in the therapy space, it has become a much more difficult conversation. And I find that to be problematic, that it is an inconsistently held standard, where in one place you can talk about real world evidence and the other it becomes more politically charged. So I think that there is value. It doesn't mean that it's the end all be all, but there is a need to make sure that it is incorporated and that we are using more real world evidence for treatments, especially those that have limited populations and high costs.
Stuart, that's a fantastic point. It has to be a two-way street. Appreciate it.
Yeah.
Well, we are running out of time. And in fact, we're a little bit over, Stuart. So thank you for spending some time with us on this. And thank you for all the questions. Stuart, we appreciate your efforts on behalf of rare disease patients and your enthusiasm for tackling some very difficult issues. And we look forward at RAAP to working with you as the discussions proceed.
Perfect. Thank you so much for having me, everyone.
Thank you, Stuart. At this time, we'd like to move to Congresswoman DeGette. Congresswoman DeGette wasn't able to make it with us this morning due to her committee schedule, but she was really excited to share some information with us and update us about Cures 2.0. As many of you know, and many of you have worked with Congresswoman DeGette over the years, she's a fourth-generation Coloradan who has dedicated her life to serving the people of Colorado's 1st Congressional District. Congresswoman is now in her 13th term and is a leading voice in the nation's ongoing healthcare debate. She has been involved in many, many key issues over the years, from FDA reform to dealing with issues with COVID-19 pandemic, and has played a leading role in the nation's response to that. However, there's one piece of legislation that the Congresswoman is probably best known for championing, and that's the 21st Century Cures Act. That bill modernized the nation's medical research system, and it is often simply known as the Cures Act. It has been widely hailed as one of the most important pieces of legislation that Congress has passed in recent years. From cancer research to precision medicines to rare diseases, it's enabled more labs to make more breakthrough discoveries that could soon lead to new cures and treatments for patients around the world. And as we listen to our very nuts and bolts discussions with Stuart and the importance of making rare therapies available to patients, Congresswoman DeGette will be an important voice in that discussion on the House side as well. So with that, we'd like to turn the time over to Congresswoman DeGette. Kelsey, I'm not getting any sound on this end.
I think we need everyone to mute as well. Can anyone else not hear it?
I can't hear it either, Kelsey. It's
Oh,
Jeff.
we tested this morning, Mike, and it worked great. Let's try it again. Sorry.
Hi, I'm Congresswoman Diana DeGette. I wanted to thank you all for taking the time to participate in this.
Can you hear that?
In 2016, Congressman
Yes.
Upton and I got together to author a landmark piece of legislation known as the 21st Century Cures Act. That legislation, which has widely been hailed as a tremendous success, invested $1.8 billion of new funding for cancer research. It also streamlined decision-making at the FDA through the formation of centers of excellence so that effective treatments can be approved faster. As a result of the 21st Century Cures Act, researchers and scientists across the country have been able to achieve some amazing things. We have a better understanding of the human brain. We've increased research funding for Alzheimer's, cancer, and other rare diseases. We've developed new treatments for cystic fibrosis, and we're on the cusp of finding a cure for sickle cell anemia. In light of the tremendous progress we've made since the passage of our bill, Fred and I decided we weren't done yet. And so just last year, we introduced a new bipartisan piece of legislation. We're calling it Cures 2.0 to further speed up our search for new cures and treatments for some of the world's most difficult diseases, like cancer, diabetes, Alzheimer's, ALS, and more. While the 21st Century Cures Act revolutionized how we research and develop new cures and treatments, Cures 2.0 will help us deliver those treatments to patients sooner. And it will make President Biden's dream of creating a new Advanced Research Projects Agency for Health a reality. Immediately after meeting with President Biden in the Oval Office last year to discuss his plan for creating ARPA-H, Fred and I have been working with our congressional colleagues to make it happen. And we are hopeful that we'll be able to get this exciting new agency up and running soon. Modeled after the Pentagon's highly successful DARPA program, which has been responsible for developing some of the most consequential technologies of our time, like the internet, GPS, and self-driving cars. ARPA-H would be run by a relatively small number of program managers who would each be given the autonomy to choose which projects to pursue. Like DARPA, ARPA-H will bring together some of the nation's greatest minds and give them access to the federal government's seemingly unlimited resources. It's a task that will make the impossible possible. It will reshape the future of biomedical research in this country and help push our research potential far beyond what we can even imagine. For those of us who have devoted so much of our lives to improving how our nations care for patients in need, I can tell you the future is bright. And I can't thank all of you enough for your continued support along the way. I wish I could be with you there in person, and I hope to see all of you soon. Until then, keep up the good work, and I hope you have a wonderful event.
Well, thank you, Congresswoman DeGette, and we sure appreciate the effort that she put into providing us with that pre-recorded message. With that, I am going to turn the time over to Jeff Oldham and our state panel. And Jeff Oldham is our RAAP State Government Affairs Director. Many of you are getting to know Jeff through the efforts that Jeff is putting in at the state level to build the RAAP policy agenda and capabilities to pass some of our core legislation, which you're going to hear about in his session. So with that, I'd like to turn the time over to Jeff and his panel, who include many wonderful and experienced voices in the rare disease community who have been working on many important issues that affect our patients. Jeff?
Thanks, Mike. Can everybody hear me okay? I'm having some technical problems this morning. All good? Okay, great. Mike, thanks again. And thanks to everybody for joining us today. We're really excited about the state panel that we put together. Quickly, and those of you that have been on the state calls have probably heard this a few times, but I'd like to just give you a little background on where we've been this year and where we're looking to go next year. Obviously, there's a lot going on at the state level. So our goal to start 2022 was develop policy documents, distribute those documents around our core issues, distribute those documents to key influentials, legislators, patient groups, and the like. And then secondly, to get some legislation introduced. That may have been, and that's my oversight perhaps, but that may have been a little too aggressive. As most of you guys know, that the alliance development process is pretty time consuming. So having said that, I think we're in a strong position going into 2023 to introduce some of our proactive legislation. But just to give you a summary of the alliance development process, again, we're in 7 states that we're focusing on. I have reached out to, or my colleagues have reached out to well over 100 organizations in those states, maybe 150 to 175. Of those, I've got a tentative agreement, which means they agree with us on the issues, but they need a little more information, which we're getting them. But we've got about 88 groups in 7 states that have agreed to work with us going forward in 2023. And thanks to all of you guys who sort of assisted me in making some of those connections. Specifically on the legislator front, I've had some good conversations with legislators. There's probably about 12 to 15 legislators in our 7 states that again have agreed to participate with or collaborate with us going forward. So that's good news. I think we need to add a few more, obviously, before we get things rolling next year. So I feel really good about where we've been and the position that we're in. A couple of the issues, and we're going to expand on that with our panelists, that we've been focused on and that we'll be very focused on going into 2023. Obviously accelerated approval, and that's a federal and state level, very important to everybody. There's an issue around Medigap that we're going to talk a little bit more about in a moment. That's going to take off at the state level, I think, next year. One of our proactive pieces of legislation focuses on including rare disease experts on state decision-making boards. We think that's a real winner. The conversations I've had with legislators and groups is very positive. There's a lot of support for it out there. So we need to move that along next year as soon as we can. And then finally, copay accumulators. I think all of you are pretty familiar with that issue. It's been very successful at the state level, in my opinion, and we're going to have Stephen talk about that in a few minutes. So with that, before I introduce our speakers, does anyone have any questions for me? And again, ask questions in the chat anytime during the presentations. We certainly want this to be a discussion. So first, it's the great thing about doing this kind of work is you meet interesting patients and groups from all over the country. You have a lot of good relationships. But occasionally you get to meet somebody new. And I'm so glad that we were able to get connected with Jenny Jones, our first speaker. She's a tremendous young lady. She's challenged by 2 rare diseases, I believe. She is a tremendous advocate. She also works in the healthcare field. She's a healthcare social worker. So checks all the boxes, but she's a real nice young lady. And we're very excited to have her speak first today. Jenny, can you hear me?
I can. Thank
Great.
you.
So why don't you go ahead, maybe, Jenny, and share your story a little bit, and perhaps, or even some of your work stories, and how including rare disease experts in these decision-making panels might be beneficial going forward. Thanks, Jenny. Go ahead.
Thank you. Well, I have 2 rare diseases. I have familial adenomatous polyposis, or FAP, and short bowel syndrome. So FAP, in short, it causes hundreds to thousands of precancerous polyps in the colon to develop at a young age, and they will turn cancerous if the colon is not removed in time. And there's other risks for other cancers and other issues that come along with FAP. And short bowel syndrome is a malabsorption of the intestine or intestines that causes malnutrition and dehydration, which of course that can cause all kinds of other issues. So I was diagnosed with FAP at the age of 8 after a very long ordeal, because I was having abdominal pains that weren't stopping, and I was on an HMO insurance plan. And so, like Medicaid patients, I had to have a referral from my primary care doctor to be seen by a GI specialist for evaluation. However, my primary care doctor told my parents there was nothing wrong with me and I was just a whiny child. So my parents had to change insurance plans as soon as they were able to get me evaluated by a GI specialist. And as soon as that GI doctor heard about my symptoms and heard about my FAP family history, she immediately ordered me upper and lower GI scopes and genetic testing, which all confirmed that I did have FAP. So within a year later, at the age of 9, I had to have my colon removed because my polyps were starting to turn cancerous. I had complications, which led to several more surgeries and my second diagnosis of rare disease, short bowel syndrome. These complications also caused me to have an ileostomy for 6 years before I was able to have it reversed in high school. So these medical experiences, they led me to do two things. I became a medical social worker in 2009, and then I started Life's a Polyp in 2012. And Life's a Polyp is my blog, YouTube channel, and a shop that chronicles my life with my rare diseases and with a focus on raising awareness about them, empowering others, and raising research funds for FAP through the National Organization for Rare Disorders Research Fund that I started in 2015. The shop I started soon after that, I donate all profits to the fund. And then this year, I also wrote a children's book about FAP, and I donate a portion of those profits to the fund as well. So with these experiences, I can confidently say that the reason for why rare disease experts need to be included in state decision-making boards is simple. It's dangerous not to include them. Rare diseases are just that. They are rare. There's not enough knowledge known about them. There's over 7,000 rare diseases that impact over 300 million individuals globally, according to NORD. And so not only does the public not know a lot about rare diseases, but doctors are lucky if they have a brief overview of rare diseases in their medical textbooks when they're in school. So these boards, they require rare disease experts to be involved to allow for proper care to be provided and appropriate healthcare decisions to be made for the safety and the well-being of rare disease patients. If rare disease patients are excluded, harm occurs. And I can give you a few examples of that. Now, you remember my primary care doctor refused to refer me to a GI specialist, even though she knew I had an FAP family history, but she didn't have the knowledge about FAP. And I guess she didn't want to learn more about it. But she put my health at risk and my life at risk because, as you recall, it was within a year later that I had to have my colon removed because my polyps were starting to turn cancerous. Now, it's not common for FAP patients to require their colon removed at such a young age. Typically, it's late teens and the 20s, sometimes in their 30s if they're lucky. But it does happen, and it happened in my case. Another example is my mother. She has the same rare diseases that I have, and she has a permanent ileostomy. This year, she was hospitalized because she had a partial intestinal blockage. And I'm not sure when the hospital changed their policies, but she was not seen by a GI specialist her entire stay, which was abnormal for us. Instead, she was followed by a surgeon, a general surgeon, who was not specializing in colorectal surgeries. This surgeon wanted to keep putting my mother on blood thinners, saying it was protocol. Well, my mother, because of her short bowel syndrome, she is vitamin K deficient, which means that her blood is already too thin. She has to take medications in order to coagulate her blood properly. So that one of the last things she needs is blood thinners. And even when I asked her GI specialist about this afterwards, he didn't have any answer as to why someone would need blood thinners for an intestinal blockage. And when she asked her surgeon that was following her why she wasn't being seen by a GI specialist, the surgeon asked her, why would you need to be? Well, this is a woman with two rare diseases that are GI-related diseases with GI issues. Why would she not need to be seen by someone who specializes in her conditions, in her issues? Someone without knowledge about her conditions was making healthcare decisions for her, about her, that were dangerous to her life. In my work, I work with several Medicaid patients, and these patients tend to have a lot of health issues, and they are some of the most vulnerable individuals of our society due to their socioeconomic status and difficulty accessing resources. And I've seen the challenges of them getting proper care, of obtaining referrals to see specialists, of getting approval for medications and treatments. And I've experienced some of that myself too. I have a different insurance plan that does not have the same state medical decision boards that follow them, but iron infusions are one of my hardest things to get approved by insurance. It takes nearly a month for me to get approved for my iron infusions. And due to my short bowel syndrome, I have anemia. And I also, my other electrolytes have issues. maintaining balance. However, I also have severe dehydration because of my short bowel syndrome. And so on paper, my labs look fine because they are so concentrated in my bloodstream because of my dehydration. They are falsely high. But it takes someone with understanding of my rare conditions in order to understand why I need iron infusions and why I'm not actually okay, even though I look like I am on paper. And all this is to say that it takes specialized experts to make the appropriate decisions that affect someone's health, especially when dealing with rare diseases and some of our most vulnerable individuals. I appreciate your time.
Thanks so much, Jenny. That was very inspirational, and thank you for being so open and honest with the group. I know they appreciate it. One quick question, and you may or may not know the answer to this, so don't worry if you don't, but of the patients you see, would you perhaps guesstimate which percentages have rare disease? I know that may be not answerable, but.
I know at least one of my patients does, and it was a rare disease I had never heard of, but I don't know all the comorbidities that some of them have. So I'd say it's a low percentage,
Mhm.
especially considering how uncommon rare diseases are.
Yep. Have you had any, again, that obviously one patient, are you aware of any therapies or treatments that, if I don't know if they're on Medicaid or not, but that have been denied as a result of lack of understanding, if that makes sense?
Well,
If you don't, but just curious.
I'm not really, I just know that it's always a hard process trying to get approval for them in order to get treatments and things. Sometimes we do have denials and then we'll have to appeal them. And so it takes a lot longer to get them the treatments that they need.
Great. Does anybody have any questions for Jenny today? Great. Jenny, I know that you took time away from work today, so I hope we don't get you in trouble with your boss. But again, I think Jenny needs to probably run to get back to work, but I just want to thank you so much, and so nice to make your acquaintance. And I know everyone on the call appreciates your time. Quickly, what's the URL for your, is it YouTube you said, or just a website?
Well, it's a website. It's lifesapolyp.com, and I have links to that I'm on there. I do advocacy, so it's all listed there.
So please, everyone, go and visit. I looked at it last night, Jenny. It's fantastic. Again, thank you so much for sharing your story, and look forward to collaborating going forward.
Thank you so much.
Certainly. Have a good day.
Yes.
Okay. Well, I'm going to keep turning up in your life like a bad penny, guys, so I apologize. We had on our Medigap discussion, we had a tremendous patient group leader that really wanted to do it, but she had a conflict. So obviously we understand that. But I'm going to talk a little bit about it. I know there's a couple of folks on the phone that are probably a little more knowledgeable than me on this. So, you know who you are, and feel free to chime in. Just quickly, everyone knows Medicare, obviously traditional Medicare, excuse me, Medicaid, I apologize. Everyone knows Medicaid, and Americans who turn 65 get it automatically. They're enrolled. It's good, it's great. And they're also allowed to enroll in Medigap plans, which covers things that Medicaid does not cover. The challenge here is, I think it's about 1 in 6 Americans that are enrolled in Medicare, Medicaid are not 65. They're folks with disabilities or diagnoses like ALS or end-stage renal disease, very, very debilitating conditions. So while they're eligible for that, they are not guaranteed access to Medigap. And as we all know, that's a tremendous cost associated with that. I think going into next year, I know there's a couple of states that are moving this type of legislation this year. I think it's Kentucky, Vermont, maybe a few others. But based upon the conversations I've had and folks I've outreached to, there's a tremendous amount of support around this issue. And I'm working with some folks that are part of RAAP to sort of put together a pretty tactical plan going into 2023. I believe Tennessee and Texas are two next year that we're looking at, and there's a third. So to sort of close, again, this is not, in my opinion, not really well known yet. We need to do some education. We need to do some alliance development in our states. And again, the feedback we've received thus far has been very positive. So we're excited about taking this on. It's going to be one of our priorities for next year as an organization. And I think it's a winning issue. So with that, I'll open it up to the floor. If there's anything I've missed or haven't covered, feel free to backfill or just ask any questions about it. Anyone? Okay. Well, you guys are letting me off easy today. Again, feel free to reach out to me. We've got some talking points that we're working on, but we're very excited to roll this out in 2023. Okay, next speaker, we're going to be talking about copay accumulators and maximizers. Again, I want to introduce Stephen Schultz. Stephen works, I think he's a state legislative director for the Arthritis Foundation. And a lot of us have been involved in the Medigap issue over the last couple of years. It's been tremendous, in my opinion, as a state proactive issue. I think it's been very successful, and Stephen is certainly part of that success. I think Stephen, you may have said this, I think we're at 17 states that have passed this thus far, and a couple more that will close, I think. So we're excited about going into 2023. But Stephen, you're the expert, and I will turn it over to you. Thanks.
Yeah.
Yeah.
Thank you for having me, Jeff. Thank you, everyone, for allowing me to speak on this issue. One that familiar with just as is in my role with the Arthritis Foundation, but also as co-chair of the state subgroup for the All Copays Count Coalition, a group that, if you're familiar with the Accumulator Adjustment Program issue and maximizers and the issue of copay assistance in general, a group that you might have heard of throughout this process. And so just thank you for the opportunity just to talk a little bit about this issue. Like Jeff said, we've had tremendous success at the state level that's led to federal level momentum getting going. But we're up to 13 states, hopefully 14 states. One state's on the governor's desk. We'll talk a little bit about that as we get going. But you can move on to the next slide. It's just kind of an overview. If you're not familiar with accumulator adjustment programs, kind of the very quick kind of discussion about it is that I think you may be familiar, if you're familiar with chronic conditions, chronic and rare and serious disorders. Many of our patients take copay assistance. They use copay cards, manufacturer assistance, to be able to afford their life-saving medications. A more recent program that's been added just in the last half decade or so have been copay accumulator programs that really block that assistance from counting towards the patient's cost sharing. So their deductible, their annual out-of-pocket cost maximum. So what's happening is that they're able to still use their assistance, but they're going pharmacy counter, going and paying for the medication, paying. The assistance is draining, but the assistance is not counting towards the cost sharing. So there's going to be a situation where the patient's going to run out of that assistance and have to figure out how to pay for their medications without kind of that help from their assistance programs. And then all the while that allows the PBMs and the insurers to essentially double dip, take the assistance from the copay assistance on one level, and then from the patient for the same exact cost sharing. So a huge issue as far as being able to afford and stay to their medications. Next slide, please. So what are some of the trends? We have some great partners in this, and I'll talk a little bit about that. But an element of that is that we need them to be able to kind of come up with kind of what's going on, what's the status of some of these. And one of those partners has been AIDS Institute, who's done a great report and great research as far as what's the landscape in the states as far as copay accumulator programs. And they have published a report, an updated report on kind of where we are after some of the successes we've had in the states. But 35 states have at least one plan with a copay accumulator. 8 states, every single plan in the state has a copay accumulator. So if you're a patient who's even well aware of this, and many patients aren't, but even if you are a very educated patient that knows about this issue, says, I want to avoid this, in 8 states, you really can't do anything about that. You have to kind of sign up for a plan that has one, and you're in a rough spot. 30 states, at least half. So you're really kind of, as a patient, really kind of in a bind there as far as finding a plan and digging in and finding a plan that doesn't have an accumulator in it. And there's only 3 plus DC that have 0. So there's only like 3. The other landscape in it is that just kind of is pretty much what we anticipated, but we had a great survey that Arthritis, National Hemophilia Foundation, American Kidney Fund, and others participated in, that really showed that 6 out of 10 patients and caregivers said that they'd be in extreme difficulty of affording their medication and treatment without copay assistance. So that just kind of stresses how important copay assistance is for chronic and rare disease patients. Now, in the next slide, just to kind of show kind of how difficult some of this language is in contracts around accumulators, and the really element of insurers of PBMs to block assistance from counting is that you'll kind of read through this language, and it's very wonky, very legalese. And so if a patient, even if they find it, like you see on the bottom there, it says page 43 of 82, even if they find this in their plan details, to read through this, it's going to be a struggle to kind of for someone that's not familiar with healthcare. And even if you are familiar with your health insurance and know all what things to look for, it's not something that's going to kind of really be something that you know right from the bat that this is language that's blocking your assistance from counting. There are some insurers that use very plain language, but even then, it sometimes can be kind of built into the contracts on kind of like I said, page 43. So I think that's one of the issues that we're dealing with, is not only just the issue of how bad the programs are, but then also education and awareness about these issues, and finding them in contracts can be a little bit difficult. We'll move on. So what are we doing to combat it? I mentioned All Copays Count Coalition. We have model language that ensures that payments paid by the patient or on behalf of the patient should count towards the patient's cost sharing. Pretty simple language. We've got endorsements from the AMA, ACS CAN, AIDS Institute, National Hemophilia Foundation, Cancer Support Community, Immune Deficiency Foundation, many others in the rare disease. We have a very diverse coalition, just because this is something that touches upon all chronic and rare disease communities. And so I think that's kind of been one of the beautiful things about this, is that just it's been a very diverse coalition with a lot of groups really helping in what you'll see next in successes across the states. So as I opened up, 13 states currently have enacted some form of legislation to really ensure that all copays count. Washington was the most recent state that just got something signed into law earlier this year. There's one state that I mentioned, Maine, that's on the governor's desk. There's probably a few more states on the board currently that have legislation that we may be able to get over the finish line this year, that are very close, or that we anticipate having the opportunity for movement. There are a number of these states that already are kind of looking at an eye for next year, or kind of having a hearing this year, but knowing that the big push will be in 2023, where there's a little bit more time. A lot of these states have quicker sessions this year, maybe they're budget focused sessions, or they're kind of trying to get out as quick as possible to focus on their reelection campaigns, which is very common in an even year session. So I think we anticipate that 2023 will be another big year like it was last year for this issue, because we'll have a lot more states in session. Crystal, who will talk next, kind of a big champion on the bill in Texas, which not in session this year. Nevada's not in session this year. Montana not in session. So there's states like that, let alone some of the states that are kind of maybe going to think about introducing legislation for the first time, or have a little bit more time to get something over the session. So I think even though we'll have, I think, a good session this year, I think 2023 will be another banner year. And just one of the last slides here is just talking about kind of why we've had success on the state level, is that this is something that I think a lot of legislators get, as far as, we're going to help patients. And sometimes patient access issues can kind of hit a bit of a wall, because they can be cost drivers, or at least kind of the front end could be a cost driver, and you have to really sell the idea that and show the facts that, okay, this may raise costs in the front end, but in the back end, it's going to help patients, help the healthcare system in general. Whereas this is an issue that we're able to show, hey, this is not something that's touching government assistance. It's not going to touch our Medicaid program. So for the most part, most states have shown that this has no direct impact to the state. This is something that's really going to impact maybe the insurers, PBMs, but that's the policy discussion at play. So I think this is one of the biggest elements, is that even in the toughest states of where fiscal notes have hurt other patient access issues, we've seen kind of no fiscal impact to the state as a result of it. So I think most legislators, if you're telling me this is going to help patients, help people, help my constituents, and not cause any financial impact to the state, it's going to be something that's going to help, and probably get an eye vote from a legislator. And then I think the last slide, there's ways that you can help. I mentioned 2022 and 2023 legislative sessions. Kind of any way you can help in building momentum. These All COVID Coalition is just a patient provider organization, and kind of in each state we have kind of patient providers really taking charge of it and driving the train, saying, here's the version we want to run with, and everything like that. So if you have connections to the states, I think now is the time that we're really kind of looking at kind of how do we plan for 2023 and maybe get some of these 2022 bills over the finish line. Federal, I mentioned we've got the Help Co-Pays Act on the federal level. A lot of that's momentum has occurred just because of all the state victories. And so I think as many as we can kind of continue to build co-sponsors for the federal level will help maybe get us over the line on the federal level in the years to come, or at least put pressure on the administration to really kind of do something that they can do through the notice of benefit and payment parameters, and really fix this issue. Bubble up stories, speak to your experience. I think patient stories are really the heart of why this has been successful. I think we've been able to bubble a lot of stories up to groups who then say, hey, this is an issue that we need to solve. And some of these victories would not have occurred without patient stories. And keep an eye out for further escalation. I think plans, PBMs are identifying that okay, we're losing the battle on these bills. And so they're maneuvering towards things like maximizers that Jeff mentioned at the beginning, which is kind of still taking the assistance in, but never getting really to the point where the patient is getting that pharmacy counter. So they're kind of spreading it out through the plan year. So kind of creating a different issue. Or there's different programs out there. You may have heard of things like Save on SP and things like that. So there's definitely going to be kind of a further escalation on this issue as the plans and PBMs kind of identify, we're losing this battle, or we're kind of not, we need to figure out a different way to continue to kind of take in this assistance without counting it, or try to at least. I think one of the biggest elements that you can do to help is employer education. I mentioned the big element in the fact that a lot of patients, a lot of employers don't even know that this is in their plans. I can reveal that kind of we talked as an arthritis foundation kind of with our HR and said, hey, do you realize that we have an accumulator in our RISA plan that we're offering patients, and this is something that we're fighting. And so I think even kind of the most educated are aware. So, but I think if there's something where as a patient, you're able to sit down with your employer and say, hey, our plan has an accumulator. This is how it impacts me. Are we able to look at different plan options or talk with our plan sponsor kind of about different options that may not have an accumulator? And I think the more that employers that are aware of that, especially larger employers, we're really helping move that momentum even without legislation. I think that's it. I'm happy to answer any questions or concerns, even if it's something where it may hit you late at night, just because I know it's a complex issue and a little bit wonky. And so something where offline I can be of assistance and talking through the issue. I'm always around.
Any questions for Stephen? Well, just to sort of tie this up with a bow, I think the coalition that Stephen's running is, in my opinion, textbook on how to be successful in what we do. Tremendously organized. They have calls every other Friday, which are fantastic. But they did their alliance development work. They have a lot of good third parties. They've educated folks in a good way about how to weigh in, and obviously the results speak for themselves. They got 13 and they're just getting more states all the time. So Stephen, thank you so much for your time today. I know you're traveling today too, so thank you very much. Look forward to talking to you soon, my friend. Okay, last but certainly not least, Crystal Davis. Again, Crystal, and I apologize in advance for badgering you this week and even last week. I've tried to chase you down, and thank you so much for speaking to me and agreeing to do this. I think pretty much everyone on this call knows Crystal. If you don't, look her up, go to her website. I think she's one of the foremost patient advocates in the country, probably around the world, and she's tremendously busy testifying, helping folks out, talking to legislators. Today, she's going to talk to us, obviously, about an issue that's tremendously important, accelerated approval. I know she's testified, I think, in front of Congress, Crystal, correct me if I'm wrong, but at the state level as well about the issue. So I will shut up and turn it over to Crystal, and it's all yours, Crystal.
Thanks, Jeff. It's a pleasure to be here today. And I'm Crystal Davis, the founding president of Texas Rare Alliance, where we work to make Texas a state of access for nearly 3 million Texans living with a rare disease. Thank you for the opportunity to advocate for protecting and improving access to accelerated approval pathway treatments. I want to start by sharing how our family joined the rare disease community. It helps explain why accelerated approval pathway treatments are important to me, the rare disease community, and the greater patient community. In July of 2011, doctors whisked our newborn son, Hunter, to the NICU at birth. Hunter had respiratory failure. He had tubes coming from everywhere and a ventilator breathed for him. Doctors successfully extubated Hunter after a couple of days, and we took him home from the NICU after 11 days. We thought the worst was behind us. However, Hunter lost nearly all movement at around 2 weeks of age. At one point, my husband asked if I had shaken Hunter. I could never hurt our baby, but he was in fact hurting. Doctors diagnosed Hunter with spinal muscular atrophy when he was 8 weeks old, and our worlds forever changed. SMA is like ALS in babies. It robs the ability to move, swallow, and ultimately breathe, and is the #1 genetic cause of death for infants. A doctor told us there's no treatment and no hope. He advised us to take Hunter home and enjoy what time we had left with him, which he expected to be around 3 months. We couldn't afford to listen to the doctor's advice. The stakes were too high. With the help of a researcher, we manufactured a compound in the US and took it to Mexico for a trial. 8 weeks after his diagnosis, Hunter was the first SMA patient to receive a disease-modifying treatment. Hunter is now 10 years old. Today, let's focus on the FDA-approved SMA treatments in the US. The FDA approved the first treatment for SMA, an antisense oligonucleotide, or ASO, on December 23rd of 2016. Although it was a couple of days early, it was the greatest Christmas gift the SMA community could receive. Doctors could never tell SMA parents again that there's no treatment and no hope, to take their babies home and wait for them to die. Now, with pre-symptomatic and early diagnosis, babies can grow up as average children, running, walking, and playing freely with their friends, instead of being tethered to machines that monitor, feed, and breathe for them. The thing is, the ASO treatment, the gene replacement therapy, and the small molecule medication the FDA approved for SMA are all accelerated approval pathway treatments. As wonderful, even miraculous as these treatments are, we've seen both private and public insurers take longer to develop coverage policies to include them in formularies. Innovative treatments can only help patients when patients can access them. Many of these treatments are for the rare disease community. Threats to the accelerated approval pathway treatments include the Oregon Health Authority's proposed renewal of the 1115 waiver. We know that accelerated approval pathway treatments are under attack and facing greater payer scrutiny than ever before. This means that patients like Hunter will have reduced access to the treatments that save and improve their lives. It means we'll shift from paying for lower cost, high value treatments that keep patients home with their families and return to paying for a higher cost, low value, emergent and critical care, where patients are in emergency rooms and critical care units instead of being at home with their families. That's unacceptable in any context. When you add how the pandemic has taxed hospitals repeatedly, we can see how reducing access to accelerated approval pathway treatments would overburden and negatively impact our healthcare systems. We're going about this all wrong. We need to treat rare disease patients with the dignity they deserve in providing access to accelerated approval pathway treatments. We can't afford a healthcare system that picks and chooses the patients to receive treatment, because that would morally bankrupt our society. Dr. Chris Austin, former NCATS director, has stated that rare diseases represent one of the largest public health crises we face, yet are mostly ignored. We must act faster and treat more patients. The FDA started an accelerated approval program because it recognized and understood the importance of providing earlier approval for drugs that treat serious conditions with unmet needs. Let's reframe how we think about rare diseases and other conditions with accelerated approval pathway treatments. Think of all the times we step up and act swiftly following natural disasters for hurricanes, earthquakes, tsunamis, floods, and wildfires. These humanitarian endeavors recognize the inherent worth of human lives. Rare diseases are a public health crisis that impacts the patient family, loved ones, and community. Rare diseases are a public health disaster. We need to step up and provide swift access to accelerated approval pathway treatments, because patients need and are worthy of the humanitarian aid we can provide them. And so I really want to focus on a couple of the areas that we're facing attack from on accelerated approval pathway treatments. And this includes the 2021 accelerated, the 2021 accelerated approval ICER white paper and the 2022 rare disease white paper from ICER. And really both attack rare disease treatments as increasing the cost to healthcare too much, and also attack accelerated approval pathway treatments for lack of data. And ICER really attempts to go back in and approve or disprove the efficacy of these treatments, which the FDA already does. And we don't want any ICER or any state Health and Human Services or anyone else in the Medicaid ecosystem going back in and determining the efficacy of these treatments. The FDA has a very robust staff. They look at a lot of data, and there's no way that any of these state agencies or other institutions can come close to matching the capabilities of the FDA in analyzing that data. So we need to make sure that the the FDA is and remains the authority on efficacy. And we also need to address some of the holes that ICER repeatedly leaves in its analysis. And the way that we can do that is we can ask for listening sessions with our policymakers and really everyone in our state Medicaid ecosystems, including Health and Human Services. We need to engage with them early. We need to go to them before the treatment is approved, and if possible, even before an NDA is filed for the treatment. Try to get listening sessions when positive interim data is released. Again, don't wait until the treatment's approved. And at the latest, try to get a meeting when the sponsor files an NDA for a new treatment. We want the rare disease patient community to come in as the voice that is impactful on the need for accelerated approval pathway treatments, and then also to address the clinical and economic utilities that these treatments can address. In the listening session, walk these stakeholders in the Medicaid ecosystem through a day and a year in the life of the patient and what that looks like. Talk about the treatment protocols, the medical supplies that you go through. Talk about how the condition impacts the patient on a day-to-day basis, but then also talk about the cost and frequency of clinical care, both from an outpatient standpoint and also addressing hospital care. Talk about emergency room, critical care, and general admissions. And rare disease patients need twice as much clinical care as average patients, are hospitalized twice as often, hospitalized for twice as long, and their hospital bills are significantly higher. And so these treatments do not exist in a vacuum. And when we discuss the economic cost of the treatment, we also need to make sure that we're discussing the past economic cost of clinical services that provide, at best, a baseline maintenance for the patient. And still many times, especially in the rare disease community, the patient's health continues to deteriorate. So by going on to these accelerated approval pathway treatments, we can have a shift from that high cost, low value clinical services to providing access to the treatments. And oftentimes with early and pre-symptomatic treatment, the patients can achieve an average life, and that should be the goal, and make the state understand that it's not just the cost of the treatment. We're avoiding the clinical services costs, but then also in many cases for these pediatric onset conditions like SMA, Duchenne muscular dystrophy, and so many other conditions, we can also avoid the cost of educational accommodations and interventions. So go to the stakeholders, have those discussions early and often, so we're not coming at the end after others have already filled their ears. Thank you so much. It's really a pleasure to be here today.
Thanks so much, Crystal. Anyone have any questions for her? Crystal, I've got a quick one for you. Just estimate, what is the time difference between if someone gets a therapy through accelerated approval versus having to wait? I know there's longer processes, but on average, do you know what that is? Oh,
It's you're getting a treatment significantly earlier. You're talking about years. Yeah. I think some of the time these trials are more than you'll get the treatment half as early before it played out in an average clinical trial. And I know that even in SMA, when we went to the FDA and advocated for early approval, because we believed that the endpoint had been met, we had multiple trials and they were supposed to be rolling approvals. But because we went in and we talked about how the pathway to treatment is the same, we were able to advocate for approval for all the patients at that earliest date. And so even those patients that were in the ongoing, that would have been in those rolling approvals, were able to get treatment even earlier. So there's a lot of flexibility in these with the FDA.
One more, and I think Mike has a question too. But so from the time Hunter was diagnosed to the time he got the therapies that helped him, how long was that roughly?
Yeah. So again, that is actually why I'm here today. That's what I do every day. He was diagnosed and he received his first disease modifying treatment less than 8 weeks later. So that's possible. Again, we didn't go through the drug discovery process, but when you talk about IND to clinical trial, we know for a fact that that can be achieved in less than 8 weeks because we did it.
Yeah. Well, those of you that have not read Crystal's story, you should do it because it's amazing. Mike, do you have a question?
I do. And thanks, Crystal, for your time. And I was thinking about something that Stuart said at the beginning about the importance of trust in FDA and doing, efforts to increase that trust, because as you know, when we talk to Medicaid directors, they will often ask, well, what's the difference between the data in a full phase 3 and accelerated approval? Is the data, et cetera. So how can we enhance FDA's trust to these state policymakers and decision makers so that they understand that the data is robust, it's thorough, and that the FDA approval didn't really skimp corners to get there? How can we tackle that issue of trust?
Yeah, I think that transparency is really key in trust. And if you look at the FDA and sponsors and clinical trials, there's not a lot of transparency there. And maybe there could be a shift from that. I think that was one of the most successful things in the COVID process. When you look at that daily interim data that really came out from Pfizer, that was out there for all of us to see. And if you went to that and you tracked it, it was really interesting. And that's something that they really did on their own volition. But why can't we do that in other spaces? Like, why do we have to hide the data and guard it so closely? Like, it's mine. I just think that opening up that data, because the data is what the data is, and ultimately it will be released. But why not put it out there and let everyone see that on an ongoing, and it really provides an ongoing interim look. And when you do that, then you can really know the moment that you meet that primary or secondary endpoint that's going to trigger the need to file an NDA. And so I think it's exciting. And I think that you're not only going to get your state healthcare systems behind it, Medicaid, Medicare, but I think you're also going to get the patient communities behind it much more and advocating for access if they can see that ongoing interim data and how it's impacting the trial participants.
Thank you.
Awesome. Anyone else have a question for Crystal? Excellent. Well, what a tremendous group of speakers. That was fantastic. Quickly, before I turn it back over to Mike to close things out, just a couple of one correction. In my haste talking about the Medigap issue, I said it was for folks that are Medicaid eligible. It's Medicare. Apologies for that, guys. My brain was behind my mouth. So, and then finally, I just want to thank the state folks. Obviously, when I came on, Mike and Evan had built a tremendous organization in a very short period of time. They did a great job. And I was fortunate enough for them to bring me on to help with the state development, but I wouldn't have been able to be successful or be in the position that we're in without our members. Just a few folks, Julie, Ben at Biogen, George at Santa Fe, Judith, Tara Britt, North Carolina, and then Randy in Ohio. Those are those and a lot of others have helped me reach out to key players in the community, and I think will continue to help us be successful going forward. So thanks to all you guys so much. You know, as you know, we're a small organization with limited resources, but I think we've come a long way. So I appreciate it. And to the speakers, thanks again for letting me badger you all week. I apologize. Mike, I'll turn it back over to you. Thanks, everybody.
Hey, Jeff, could I add one thing really quick that goes back to Mike when he asked about trust in the FDA?
Yep.
I know that when I came on the scene, I had no trust in the FDA whatsoever. I didn't trust manufacturers. And it's because of what's put out there in the media. And when you trust what's put out there in the media without having the opportunity to engage with the FDA, without having the opportunity to engage with the manufacturers, it's different from when you actually are involved in the process. And so going back to Mike on how can we increase trust, that's on us again. That's on the patient communities. That's on us to say, well, that's not true. We can send letters to the editor. We can ask for them to portray the process more accurately as citizens who are actively engaged in the process. So we need to make sure that what is put out there is more accurate and is not misleading from those who are not in the know, so that trust does build rather than get continually deteriorated.
It's a very good point, Crystal. Thanks for bringing that up.
Well, thank you,
Mike,
everyone. And thank you to our panelists. And I do want to end on that note, Crystal, and one of the things that I think that Cures 2.0 actually did to encourage that is get patients more involved in the development of these therapies, whether it's from generating the natural histories, working with companies on registries, understanding the data sooner, being more involved in gathering real world evidence, and then engaging in the FDA. That there has been a concerted effort to get the patient community more involved in the drug development process. And I think to Crystal's point and to Stuart's point, a lot of the effort moving forward is to get those same patients engaged who are now educated, they're therapeutic experts, they understand both the disease as well as the patient journey and the therapy, and getting them more involved in the access discussions on the other side of approval. Whether it's with a state Medicaid program, whether it's with a commercial payer, or with a Medicare, payer, to get those patients who are now so knowledgeable to share that information and help them make better decisions. And I think that's one important point that I think is worth us coming back and working on. And I know at RAAP, that's one of our key efforts and why we believe so strongly in patients being involved in P&T decision-making, is for that very reason, is because those patient advocates today are far better educated than they were 20 years ago, or 15 or 5 years ago. And that perspective is important to the coverage and access discussions and determinations. So thank you, Crystal, for capping that off for us. And thank you to all our panelists and our guests. We want to invite you to keep an eye out for the announcement for our November annual meeting. We are hoping to have that meeting in Washington, D.C. and in a live format. And so we would look forward to seeing all of you at that time. So once again, thank you. We appreciate your participation, and thank you again to our sponsor, Biogen, for your assistance and for the opportunities we have had to work with all of our both community and industry partners and collaborators. Thank you so much for your efforts in helping us bridge the gap between the patient and access to a therapy. With that, we will adjourn this workshop.
Thanks, Mike. Thanks, everybody.